not published yet. And this is my disclosure. So my talk is just to update. So I'm not going to do a huge summary of what we have. There are plenty of data nowadays for PD-1, PD-L1 monoclonal antibodies as a checkpoint inhibitor, as a backbone of most of the first-line non-small cell lung cancer advanced stage treatment. So I'm going to combination with chemo, combination with other immuno-oncology agents, combination with chemo plus minus other IO agents and other agents, and also a little bit on novel immunotherapy. So first study that I'm going to report to you, it was just reported a couple of months ago in ESMO Paris 2022. The study's name is Ipsos. So it seems that this is a simple design, atezolizumab versus chemotherapy. Monotherapy here, investigator's choice of vinorelbine or gemcitabine. So you know that for those who use monotherapy, those patients had a poor performance status, or they had old age, meaning that this is the inclusion criteria here. Look here. This is a study to test whether you can use atezolizumab as monotherapy for those poor performance and elderly patients. So here is the response rate, as you can see, 17% versus 8%. So we know that the response rate for monotherapy is roughly 8%, but for atezolizumab here, regardless of PD-L1 status, it was 17%. If you look at the overall survival, it was better for atezolizumab, 10.3 months versus 9.2 months. And it was statistically significant. And also PFS was better for atezolizumab. So the conclusion was that in patients with locally advanced metastatic non-small cell lung cancer, first-line atezolizumab can be useful for patients who had a compromised performance status, as well as older age. But one need to know whether majority of patients had older age or majority of patients had poor performance status. And so if you look into the detail, you can figure out that probably roughly 2/3 of patients had PS2 or plus, meaning that 2 or 3, and only a few patients had age less than 70 as their inclusion criteria. So for those patients who had poor performance status 2 or 3, the hazard ratio here was 0.86. So probably it was known that immunotherapy is also not actually poor predictive factor for patients who respond. But Ipsos study certainly demonstrated that for poor performance status is still better than the current standard of care, which is monotherapy of vinorelbine or gemcitabine. And the next study is Javelin Lung 100. And this is a large study, first-line testing a PD-L1 inhibitor, avelumab, versus chemotherapy. But this study has a very late start, meaning that this study started after most of the first-line study been ended. Therefore, you can expect a lot of crossover in the second line, and also there was some problem at the beginning for the frequencies of the avelumab that to be given. So you can see that in the first part, avelumab 10 milligram per kg was given every 2 weeks versus chemotherapy. But then it was figured out that avelumab half-life was not long enough. Therefore, it was chosen to use every week and test in the safety run-in, and then randomized to every week 10 milligram per kg, meaning that in this population, the dose simply was doubled. And in addition to that, there are multiple endpoints to be tested: PFS, overall survival, as well as high PD-L1 status. So at the end of the day, although you can see that avelumab was better than chemotherapy here in 20.1 versus 14.9 months in PD-L1 high population. This is another schedule, 19.3 versus 15.3 months. But none of these meet the statistically endpoint, meaning that it was regarded as a negative study. But obviously, you can see that at least from the PFS, from the overall survival, it was compatible with what the other checkpoint inhibitor should perform. Therefore, a good drug, a useful drug, which was approved for many other type of cancers, such as the first one, Merkel cell, a real type of skin cancer, but was not successful in the lung phase 3 study. And one thing that you need to remember is that the PD-L1 antibody used here, it was 7.3-10, and this one is highly sensitive, meaning that 80% of this of population being positive, tumor cell being positive, is equal to 2-3, 50% or higher. So when you see the detail of this study, you have to take this into account. Next study that I'm going to discuss is toripalimab. And this is a Chinese PD-1 inhibitor. The study's name is CHOICE-1. As you can see, this is very similar to a combination of chemo plus PD-1 inhibitors versus chemotherapy alone. So this study was performed solely in China, and you can see that in PFS, the endpoint was met. This was reported last year in World Lung. And the adverse event profile was no different from the other combination with chemo or chemotherapy alone. And the endpoint was met as a primary endpoint. So toripalimab was shown to be sort of equally effective compared to other PD-1 inhibitors. And if one separates into subset of patients, you can see that better PFS was found in patients who had high TMB, and also better overall survival was found in high TMB. And for PD-L1 expression, it was also shown that TC more than 50% had a higher low hazard ratio compared to those who had less than 1%. So all these data were compatible with what we know about PD-1 inhibitors. So toripalimab is additional PD-1 inhibitor that entered into the market. And very important message that was reported in ESMO 2022 is the regimen that we use almost every day for our adenocarcinoma of the lung advanced stage, which is in Keynote 189. This is the most popular regimen that has been used for this population. And remember, these patients should not have any driver mutations. So what's been reported new here is a 5-year survival follow-up. As you can see, 60 months is 5 years, and most of the ticks are here, located here. So what we want to know is whether using chemo plus pembrolizumab, we can have some of those patients being almost long-term remission or even cure. So if you look at here, 5-year overall survival, it was close to 20% versus 11%. Remember, the chemotherapy, most of these patients also receive immunotherapy at the end of the day. So 11% certainly was not the historical 5-year survival for patients who had been this status. But if you look at the progression-free survival, the 5-year was only 7.8. But remember, for those patients who had progressed, not necessarily they're not cured, they're not having any long-term remission, meaning that in this type of drug, sometimes PFS progression doesn't mean that these patients are not really controlled due to some minor population of pseudo progression, etc. Look at this Poseidon. Poseidon is a very large study randomizing 1,000 patients to 3 arms. One is chemotherapy alone. This is standard of care. The other is durvalumab plus chemo. But what was special about Poseidon is there is an arm using durvalumab plus tremelimumab, meaning that this is similar to 9LA regimen, but the cycles numbers were added to 4 cycles and followed by maintenance. So multiple endpoint again for this study, so a very lengthy study, but PFS and overall survival were a co-primary endpoint. The study was claimed to be positive, and in fact, in durvalumab and tremelimumab plus chemotherapy, this arm was shown to be superior in both progression-free survival and overall survival, and the study and this regimen actually had approved just a few days ago by US FDA. And what's new about this subset analysis was to take out the KRAS mutant and STK11, KEAP1 mutations and analyze their overall survival and show that indeed, even if you have these mutations, using the full combination was still better than chemotherapy, although small number of patients statistically will not be significant, but a trend was shown. And this was reported this year in World Lung. And so the overall survival shown here as an update. As you can see here, at 4 years, even 5 years, you can appreciate that the combination had shown to be a roughly close to 20%. Here, almost plateau. So 4 combination seems to be similar to 3 combination, but as you can see from the other arm of durvalumab plus chemotherapy, it was not up to what we expect. Therefore, for durvalumab plus chemotherapy, we probably should add tremelimumab as indicated in the FDA approval. But the result will be very similar, and in fact, the side effect profile seems to be similar as well compared to 3 combination. Canopy is a phase 3 study try to figure out whether canakinumab, which is an anti-IL-1 beta, is useful for first-line treatment combination with pembrolizumab and chemotherapy. So what is canakinumab? It was a anti-IL-1 beta blocker and had shown very good protective effect for lung cancer to occur in a large cardiology study. This study actually have shown that canakinumab can protect heart disease patients from dying, but also shown that the incidence of lung cancer was reduced in the very large study. Therefore, it was expected that this drug can be useful for either prevention of lung cancer as an adjuvant or as a first line or second line. So 4 large randomized studies were performed, but this was the last one that was reported to be negative. As you can see, absolutely no difference in terms of PFS or overall the survival, adding canakinumab to the standard of care, which is pembro plus chemotherapy. So this drug seems to be out for cancer treatment. So Sunrise is a Chinese study. As you can see, both drugs were Chinese drugs. This is sintilimab, and this is a PD-1 inhibitor plus alotinib, and this is anti-angiogenesis inhibitor. So this is a chemotherapy-free regimen compared to chemotherapy. The study's name is Sunrise, phase 2 study presented at ESMO just recently. Here, chemotherapy-free regimen showed an overall response rate of 50%, and chemotherapy 32.6%. Very interesting result. Duration of response was also better for combination, and as well as PFS was better for combination. So at least for this study, the patient number was not large, only 34, but it is interesting that this combination presented with Dr. Han in China, in Shanghai. This combination is worthwhile for further investigation. And remember that it was also investigated that pembro plus Avastin seems to have some good response in phase 2 study, but that kind of study was not continued because of the later response rate cannot be duplicated. Therefore, it has to be clear that small studies need to be confirmed. And MEDI 5752 is a bispecific antibody combination of PD-1 and CTLA-4. And this bispecific antibody did have some very special activity in patients who had non-small cell lung cancer or renal cell carcinoma, and these are the two diseases that were studied. And this was a report first for the combination with chemotherapy. Monotherapy alone, there were some responses, but ESMO 2022, the combination with chemotherapy responses were shown as here. The dose chosen was 750. Original dose was 1500. It was proven to be too high combination with chemo. So overall response rate 44.4%, and it seems to be quite high. And this was compared to pembro plus chemotherapy. So so this, although this is a novel bispecific antibody, but with that small difference, we're not sure whether this can move on, but definitely PFS was better for the MEDI 5752. This study are still continuing, and hopefully we can see some interesting result. For renal cell, MEDI 5752 is a very effective agent. So hopefully this drug can continue to work out in the future. Okay, so in summary, we discussed in the past 15 minutes key data for ASCO, ACR, World Lung, ESMO. For monotherapy, atezolizumab and avelumab shown to be effective as a monotherapy, but due to the study design, the avelumab did not meet its endpoint. Combination with chemotherapy, we discuss agent such as canakinumab, which was negative, and other novel PD-1 inhibitor, toripalimab. And we also discussed the 5-year long-term survival in Keynote 189 and Keynote 407. These are quite promising. For combination with chemotherapy and anti-CTLA-4 PD-L1, Poseidon study was positive for both overall survival and progression-free survival, and approved in US FDA. So this is a new agent that you can consider. And the combination with other agent, we discussed Canopy, and this was negative again. So for Sunrise, this is Chinese PD-1 and anti-angiogenesis a small study that has shown to be interesting compared to chemotherapy in terms of PFS and response rate. For novel immunotherapy, there are several new agents being developed. One of them, I took one of them that is quite interesting, MEDI5752. It is a PD-1 CTLA4 bispecific monoclonal antibody that has shown efficacy in renal cell and non-small cell lung cancer. Now the combination with chemo is in progress and was reported. So hopefully you get some new information and we can continue our effort in this advanced non-small cell lung cancer treatment. Thank you very much for your attention.
Thank you so much, James, for the excellent and comprehensive overview of the immunotherapy in the first-line situation. So we do see that there is actually an additional mileage to the development of IO in first line. But of course, after the first-line IO, we have to confront with the resistance. So today, we have invited Professor Mingju Ang from Korea. She is a professor of hematology, oncology, and Department of Medicine in the Sukun Kwang University in Seoul, which is also working in the Samsung Medical Center. She's definitely the leadership in multiple trials in lung cancer, and certainly an expert in the area of immunotherapy and targeted therapy. So, Professor Ang.
My name is Myung-Jun from Samsung Medical Center, American oncologist. First of all, I'd like to thank Organize Committee for inviting me to this symposium. Today, I'm going to talk about how to overcome the resistance to the immunotherapy in non-small cell lung cancer. These are my disclosures. Cancer immune cycle is well known, and lots of effort have been made to develop agent targeting each component of cancer immune cycle. During the last decades, the tremendous improvement of clinical outcomes in non-small cell lung cancer with immunotherapy, especially immune checkpoint inhibitor. In advanced non-small cell lung cancer without oncogenic driver, immune checkpoint inhibitor revolutionized the treatment paradigm in lung cancer. Immune checkpoint inhibitor monotherapy or chemo-IO combination, according to the PD-L1 expression, significantly improved clinical outcomes. So pembrolizumab, atezolizumab, cemiplimab monotherapy was approved in non-small cell lung cancer patients with high expression PD-L1 with long-term follow-up of the KEYNOTE-294. 5-year overall survival is 2% for pembro versus 16% for chemotherapy. IO plus chemo is also approved regardless of PD-L1. Long-term follow-up study of the KEYNOTE-189 showed the median overall survival was 22 months for chemo-IO versus 10.6 months for chemotherapy. Nivo-EP combination also showed the promising longer survival, 20 regardless of PD-L1 status. However, in altogether, the median overall survival still remains less than 3 years. And after progression, there is a limited treatment option as a salvage therapy, suggesting a huge unmet medical need. In our multicenter retrospective study in Korea, patients who complete the 2 years of immune checkpoint inhibitor achieved 81% of PFS and 96% of overall survival at 12 months. As you see, the patient who achieved the CR or PR experienced quite long-term survival compared to patient who achieved SCD, suggesting initial response is quite important. However, patients treated immune checkpoint inhibitor eventually develop resistance. Intrinsic resistance means a lack of initial response or clinical benefit to therapy. Acquired resistance means that disease progression after initial period of clinical benefit. So resistant mechanism comprised of tumor intrinsic and extrinsic mechanism. Intrinsic mechanism include the loss of neoantigen, defective antigen processing machinery such as beta-microglobulin loss, or abnormal interferon gamma signaling such as JAK-STAT pathway alteration. abnormal genomic signaling like PTEN-loss, STK11, KEAP1 mutation, or overexpression of oriented signal. And the extrinsic resistant mechanism include activation of other checkpoint inhibitor, TIGIT, ROCK3, TIM3, and etc. Or other immunosuppressive microenvironments such as Treg, MDSC, M2 macrophage, where the immunosuppressive cytokines IL-10 or TGF-beta are released. So there are various strategies to overcome resistance. So for first, increase the tumor visibility to immune system by induction of immunogenic cell death from the chemo, radiation targeted and oncolytic virus. Secondly, the enhanced T-cell infiltration using the CAR T-cell, TCR T-cell therapy, and the removal of a tumor microenvironment barrier like anti-VEGF, and enhancing the T-cell, NK T-cell cell function using other immune checkpoint inhibitor. I'm gonna show you later. And the restoration of abnormal interferon gamma signaling using the interferon gamma or STING agonist, or finally manipulation of microbiome to change the suppressive microenvironment. So the immunotherapy treatment can be functionally classified as those that increase the tumor specific T lymphocyte and the temper with inhibitory receptors on lymphocyte, or act agonistically activating the receptors of the immune system, and finally remodeling the tumor microenvironment. So to overcome the resistance or enhance the efficacy, there is a rationale for a combination approach for each treatment strategy. So until now, anti-PD-1, PD-L1 provide the backbone of a combination. So let me start with the agent remodeling tumor microenvironment. So the VEGF released by the tumor cell increase the number of MDSC and Treg, and also inhibit the maturation and function of the dendritic cell. So TAM release the GAS6, which bind and activate the AXL and the MERG and the Tyro3, resulting in inhibition of pro-inflammatory cytokines and stimulation of immunotherapy cytokines. So many targeted agents against Tyro3, AXL, MERG, and VEGFR have been developed. And the combination of ramucirumab with pembrolizumab showed a 30% of response rate and 9.7 months of PFS in pretreated non-small cell lung cancer, which is quite promising. In our own study, the combination of beva plus Artijo, who failed Artijo mono, showed a 12.5% of response rate, 87% disease control rate, and 5.6 months of PFS, suggesting the role of anti-angiogenic agent. And the phase 1/2 study of cabozantinib plus Artijo in non-small cell lung cancer who progressed on their prior IO showed a 90% of objective response and the 4.5 months of progression-free survival. So based on that, phase 3 study of cabozantinib plus Artijo versus docetaxel after prior immune checkpoint inhibitor and platinum-based chemotherapy in non-small cell lung cancer is ongoing. The primary objective is overall survival. Sitravatinib plus nivolumab in patients with non-squamous lung cancer with prior benefit from the immune checkpoint inhibitor showed 80% of response rate and 12.8 months of duration of response, suggesting promising. So based on this data, randomized phase 3 trial of sitravatinib plus nivo versus docetaxel in patients who progress on the prior immune check or without the chemo is ongoing. The primary endpoint is overall survival. Recently in lung map trial, combination of ramucirumab plus pembro showed a significantly improved overall survival compared to docetaxel in prior platinum and immune checkpoint inhibitor for more than 3 months treated non-small cell lung cancer. median overall survival was 14.5 months for Ramo plus Pembro versus 11.6 months for docetaxel. In another study, Lemba plus pembrolizumab showed 33% of PF of objective response and 5.9 of the PFS in non-small cell lung cancer. So based on this promising result, several randomized phase 3 study is ongoing with lenvatinib. LEAP-006 is comparing pemetrexed plus platinum plus pembro plus Lemba with pembro plus platinum plus pembro as a first-line therapy. And the LEAP-008 is a randomized phase 3, Lemba plus pembro versus docetaxel versus lenvatinib. Recently, the LEAP-003 results were presented, where the lenvatinib plus pembro versus pembrolizumab in PD-L1 more than 1% of non-small cell lung cancer as a first-line therapy. However, unfortunately, this study did not meet the primary endpoint. The median overall survival was 14.1 months for pembro plus Lemba versus 6.4 months for pembrolizumab, even though the overall objective response and PFS was significantly improved with the combination. Adenosine is one of the important mediator for the immune suppressive microenvironment and induced by the hypoxia. Several agents targeting adenosine pathway are being investigated. These include CD73 antagonist, CD39 antagonist, and adenosine receptor antagonist. So radiotherapy induced the expression of the CD73 and HLA-E, which is NKG2A ligand, which inhibit the anti-tumor immune response. So oleclumab inhibit the CD73 to reduce the extracellular adenosine production and promoting anti-tumor activity. And monalizumab blocked the NKG2A to reduce the inhibition of NK and the CD8 T cells. The COAST is the first randomized phase 2 study to investigate these three combinations on resectable stage 3 non-small cell lung cancer after CCRT were randomized either DOVA alone or DOVA plus oleclumab or DOVA plus oleclumab plus DOVA plus monalizumab. The primary endpoint was objective response. As you see, the oleclumab plus DOVA or DOVA plus monalizumab significantly improved the progression-free survival. So suggesting a combination are quite promising. So next, the tumor-specific, the T-cell lymphocyte is another the approach. Tumor-infiltrating lymphocyte therapy is already established in the treatment of the malignant melanoma. However, to further improve the efficacy and specificity, recently the neoantigen reactive T-cell therapy is investigated. So to identify the neoantigen reactive T-cells, tumor was surgically resected, and then from the patient, and part of the tumors is performed for whole exome sequencing to identify neoantigen. And then these neoantigens are transduced in the antigen-presenting cells, and at the same time, the proportion of tumors is cultured in high-dose IL-2 to expand the tumor-specific TIR. And after expansion, the TIRs are co-cultured with antigen-presenting cell, and the T cells are also analyzed for functional analysis for 4-1BB and OX40 to identify the mutation-reactive T cells. And then those T cells are re-expanded and re-infused into the patient. The neoantigen vaccine is another approach for personalized immunotherapy. Historically, the discovery of a tumor-associated antigen, which are highly expressed on tumor cell, opened the door for the vaccine approach. However, tumor-associated antigen are usually recognized by the immune system as a cell. So most of the vaccine trials failed because of the suboptimal antigen, lack of effective adjuvant, and the poor immunogenic platform. So therefore, the viral antigen or neoantigens that are unique to the malignancy may are more suitable. So to identify the tumor-specific somatic mutation, the tumor biopsy and the non-malignant tumor samples, such as the peripheral blood, are acquired from the patient and undergo whole exome sequencing to identify the neoantigen epitope, depending on the tumor type. And then it should be noted that all the mutation result in neoepitopes that are recognized by immune system because of the HLA restriction. And then the procedure for vaccine design and individualized poly-specific neoantigen vaccine is injected into the patient. So these vaccine-induced T-cell priming of T-cell can recognize tumor cell and kill the tumors. So after vaccination, the neoantigen-specific CD4 T cells and CD8 cells are induced, either de novo or boosting of existing neoantigen-specific T cell response. So these T cells proliferate and kill the tumor, which express the neoantigen. And after eradication, these responding T cells contract, but the subpopulation still remain as a component of a long-lived central memory cell or effective memory T cells. So several neoantigen vaccine trials are ongoing. Let me show one of the studies. The phase 1B trial of the personalized neoantigen peptide vaccine, NeoPV01, combined with nivolumab, was investigated in malignant melanoma, lung cancer, and bladder cancer. As I mentioned, neoantigens were identified through whole exome sequencing and the bioinformatics, the algorithm, and then make the vaccine. Before the vaccine, the nivolumab was treated for 12 weeks as pre-treatment, and the 5 priming and the 2 booster dose of the vaccine was given to the patient. So as you see, among the 82 patients, there is no SAE, and quite impressive tumor shrinkage were observed in melanoma, lung, and bladder cancer. In lung cancer, objective response was 39%, median PFS was 8.5 months, suggesting personalized neoantigen vaccine is feasible and promising. In this study, immunogenicity of NeoPV01 plus nivolumab was evaluated in peripheral blood by interferon gamma response. As you see, the interferon gamma response was increased after vaccination in all 3 tumors, and the neoantigen-specific CD4 and CD8 cells are increased in the blood and the tumors after vaccination in malignant melanoma. So these studies are quite promising, but making a neoadjuvant personalized vaccine for individual patient is quite difficult, remain challenging for wide use in the clinical practice. So next treatment strategy in the increase the inhibitory receptors. Other than PD-1 and CTLA-4, other co-inhibitory receptors such as the TIM3, ROCK3, TIGIT, PTRA, and the VSTAR. There are several agents targeting these co-inhibitory receptors are being developed and actively investigated. TIGIT is a novel inhibitory receptor expressed on the T and NK T cells, and the TIGIT inhibitor T and NK cells by binding PVR, and the TIGIT downregulate APC, leading to the increased TGF-beta. So TIGIT bind to the, and also to block the CD2 to 6 on the T effector cells. In preclinical model, the combination of anti-TIGIT and anti-PD-1 antibody synergistic improve anti-tumor activity. So based on the previous randomized phase 2 CITYSCAPE comparing TIRA Atezo versus Atezo in high PD-L1 expression showed a quite promising result of PFS and overall response. Skyscraper is a randomized phase 3 study was conducted as a first line. However, unfortunately, the press release announced that the Pembro plus the Atira plus Atizol did not meet the primary endpoint of progression-free survival, but we are looking forward to see the final result of overall survival. ROC3 is a cell surface molecule expressed on the T cells and other immune cells. Increased expression of ROC3 and CD4 and CD8 T cells inhibit T cell function. So interaction of ROC3 and with MHC triggered inhibitory activity. Clinical data suggests that anti-ROC3 and PD-1 synergistically improve the anti-tumor activity. So previously, lalatrolumab, the anti-ROC3 antibody, was investigated combined with nivolumab in melanoma melanoma. As you see, the combination significantly improved the PFS compared to the single arm, leading to the FDA approval. So based on the randomized phase 2, lalatrolumab plus nivolumab plus platinum doublet compared with the nivo plus chemo is ongoing in non-small cell lung cancer as a first line. Finally, the activation of agonistic receptor or cytokine is another approach. Costimulatory receptor antibody have two functions. Agonistic antibodies that bind to inhibitory Fc gamma receptor can promote subclustering of co-stimulation receptors, leading to the activation of CD8 cells. In contrast, the agonistic antibody that bind to activating Fc gamma receptor, leading depletion of Treg. So currently, many anti-OX40, GIRD4, BB, and CD27 antibody have been developed, but most of the antibodies did not show any significant benefit. In contrast, the high toxicity, like the liver hepatotoxicity, observed, so more investigation needed. So tumors become more heterogeneous and genomic complex with progression and drug treatment. So the treatment of the tumor with the complex polyclonal aberration is a major challenge. So I do not have time to discuss the ADC as a non-selective cytotoxic therapy, such as antibody-drug conjugate might be another options. So the ideal approach for non-small cell lung cancer patient with IO resistant need multi-layer comprehensive biomarker development. And the patient can be allocated to new therapy based on the resistant mechanism. However, this approach is not incorporated in clinical practice until now, so we have a long way to go. So in conclusion, the development of primary or acquired resistant immune checkpoint inhibitor is inevitable and involves dynamically and remains the most important barrier. Acquired resistant mechanism to immune checkpoint inhibitor is not fully understood, but more complex because of the tumor microenvironment. Resistant biomarker should be multi-layer comprehensive profile and needs for the validation. So eventually, personalized approach with combination therapy based on the biomarker is required. Finally, the deep understanding of tumor microenvironment biology in immuno-oncology field and development of predictive biomarker is necessary for next generation immuno-oncology therapeutic strategy. I'm going to stop here. Thank you for your attention.
Thank you so much, Mingju, for the very, very comprehensive, in detail talk on the resistance. Look like that we are facing a very complex situation. It's unlikely we can solve the problem in the short term. The last speaker is a good friend of mine that you know really well, Professor Yilong Wu. He is really the genuine giant in many areas on lung thoracic oncology. And today he's going to talk about the immunotherapy for the early stage disease. Yilong.
You all, good afternoon again. For this session, I will talk about what's the next for the immuno-oncology in early stage non-small cell cancer. This is a disclaimer, and this is my disclosure. First, I will introduce the overview of the current immuno-oncology paradigm in the early stage of non-small cell lung cancer, including the adjuvant immuno-oncology and the neoadjuvant setting. Secondly, I will focus on what is the next step for the immuno-oncology in the early stage of non-small cell cancer, and how to choose patient benefit from the adjuvant immuno-oncology and the role of the perioperative immuno-oncology therapy in dry the mutant non-small cell lung cancer. First, let's review the adjuvant immune checkpoint inhibitor therapy. As we know, the UNPOWER-010 is the randomized, multiple center, the open label phase 3 trial to compare the adjuvant atezolizumab after chemotherapy versus the best support care in reset stage 1B to 3A, the non-small cell lung cancer. At the World Lung Cancer Conference 2022, the primary endpoint are the disease-free survival. The updated data show that the adjuvant atezol after adjuvant chemotherapy in reset stage 1B to 3A, the non-small cell lung cancer, can prolong the disease-free survival in the PD-L1 more than 1%, the stage 2 or stage 8 population, and all the randomized stage 2 to 3A population. Based on the IMpower-010 data, FDA and the Chinese regulatory department NMPA approved the adjuvant atezolizumab in the PD-L1 more than 1%, stage 2 or 3A, the non-small cell cancer population after the resection. For the overall survival data, in the PD-L1 more than 1% patient, the overall survival trend in favor of the adjuvant atezolizumab. But I think based on the study design, this the overall survival only in the reference is not the final conclusion. Another study is the KEYNOTE-091. This study compared the adjuvant pembrolizumab versus the placebo for the early stage of non-small cell cancer following complete resection and the adjuvant chemotherapy. The primary endpoint were the DFS in the overall population and the DFS in the PD-L1 more than 50% of the population. The DFS in the pembrolizumab group was the 53.6 months, which was significantly longer than which in the placebo group. But in the PD-L1 TPS, more than 50% of the population, it did not prolong the DFS at all. Adjuvant pembrolizumab improved DFS in complete reset. PD-L1 unselected stage 1B to 3A, the non-small cell lung cancer after complete resection. This met one of the two primary endpoints. What happened in the neoadjuvant immune checkpoint inhibitor? Checkmate the A16 study. The neoadjuvant nivolumab plus the chemotherapy compared the chemotherapy in stage 1B to stage 3A to reset non-small cell lung cancer. 358 patients with the randomized 2-2 group or 3 cycles, followed by surgery with a 6-week post-treatment. The primary endpoint were the PCR and the EFS. For the ITT population, PCR in nivolumab group was 24%, which was significantly higher than the chemo alone. For the event-free survival, 31.6 months in the nivo plus chemo group versus the 21.2 months in the chemo alone group, almost 10 months prolonged. Now, I give the current treatment the practice algorithm for the reset the non-small cell lung cancer. We treat the patient in stage 1A with the surgery or the SBRT and stage 1B to 3A, the resectable or the potential resectable disease with the neoadjuvant immunotherapy, or the adjuvant TKI, or the adjuvant IO based on the driver gene status and the PD-L1 expression. Osimertinib and iconinib became the standard of care in the adjuvant setting for patients with the resected EGFR mutation in the global or in the China. The clinical trial of the TKI as a neoadjuvant therapy with or without chemotherapy is already recruiting the participants. Immunotherapy provides the long-term survival for the advanced non-small cell cancer and fast move to early stage non-small cell cancer based on the survival metric for the checkmate A16 and the I-power 010. IO has become the standard of care in the neoadjuvant and the adjuvant setting. Besides, KEYNOTE-091 improved the DFS of all patients with a compared resected early stage non-small cell cancer, regardless of PD-L1 expression state. Some clinical trials focus on different schemes are ongoing. Based on COM104 and Japanese impact clinical trial, adjuvant gefitinib led the 5-year survival reached 54% in China and 78% in Japan for stage 2, stage 3 resected non-small cell cancer. These are the best 5-year survival so far. Let's focus on DL as another. We are talking Empowered 010. Let's talk about in the I-power 010. After 46 months of follow-up for the ITT stage 2 to 3A the population, the overall survival didn't show any difference between the two groups. However, when stressed by the PD-L1 status, overall survival trends in favor of the artificial in the PD-L1 more than 1%, especially in the PD-L1 more than 50% the population. Let's focus on the DF data. In Empower 010 study, PD-L1 more than 50% population is the most benefit the population with the adjuvant artificial. On the other hand, in the KEYNOTE-091 trial, it didn't favor the patient with the PD-L1 high expressed patient. The most benefit population is different in these two trials. Let's look at the primary endpoint in the two trials. Empower 010, the primary endpoint is the DFS in the PD-L1 more than 1%, the stage 2, 3A, and the DFS in all randomization stage 2, 3A. But in KEYNOTE-091, the dual primary endpoint was DFS in the overall population and the DFS in the PD-L1 TPS more than 50%. For primary endpoint in these two studies, DFS in PD-L1 more 1%, the stage 2 stage A in the Empower 01, and the DFS in the overall population in the KEYNOTE-091 were the positive. What about the ctDNA defined subgroup? In all ctDNA evaluable stage 2, 3A the patient, median DFS was not reached in the atezolizumab versus the 31.4 months in the best support care, with the hazard ratio of the 0.69. For the ctDNA patient has a better outcome than the ctDNA positive patient. This shows that the ctDNA may be a mark to guide the adjuvant immuno-oncology of the operation in early stage non-small cell lung cancer. Next, let's start the final topic, where the driver mutation non-small cell cancer could benefit from the perioperative immuno-oncology. Neoadjuvant IO for the driver mutation non-small cell lung cancer. There are two phase 2 trials to explore the IO neoadjuvant atezolizumab plus chemotherapy and the nivolumab plus chemotherapy in patients with the resected non-small cell lung cancer. It showed the higher major pathology rate in the ITT population. For the patient with the driver mutation, such as EGFR mutation, KRAS mutation, HER mutation, et al., we also see the higher major pathology rate in patient with the driver mutation. This is the multiple center pooled analysis conducted in China. Here are the induction immune checkpoint inhibitor for the resectable oncogene mutation non-small cell cancer. 40 patients with the oncogene mutation non-small cell cancer were enrolled. For the ITT population, the overall response rate was 61.8%, and MPR was 67.5%. For the driver mutation patient, MPR was 31.6% in the EGFR mutation population. For the KRAS mutant patient, MPR was 44.4%. This trial shows induction immune checkpoint inhibitor for resected oncogene mutation non-small cell cancer is the potential treatment choice in this population, especially for the KRAS mutation. To discuss the efficacy of the neoadjuvant treatment for EGFR mutant non-small cell cancer compared to different treatment modality for the resectable EGFR mutant non-small cell cancer in regard to radiological response and pathological assessment by integrating chemotherapy and EGFR-TKI cohort on the C103. From the MPR and PCR data, we can see that the neoadjuvant IO plus the chemotherapy achieved a higher majority pathology response and the PCR than the chemotherapy alone. This is the decision tree for the perioperative treatment in the early stage of non-small cell lung cancer patient. For stage 1 to stage 2 non-small cell cancer, adjuvant EGFR-TKI or adjuvant IO is the preferred choice. For the EGFR mutant patient, adjuvant ositinib TRS, it can reduce the risk of the recurrence. For the non-driver mutation patient, we can leave the unpowered 010 trial model to choose the atezolizumab for the adjuvant therapy. For later stage patients, such as stage 2 or stage 3, new adjuvant therapy can be considered. For the non-driver mutation patient, KMF1A16 model is the choice. For driver mutation patient, you can try to use the EGFR-TKI neoadjuvant therapy, but not encouraged. We need to explore more in neoadjuvant TKI therapy. In summary, current immuno-oncology paradigm in the early stage of non-small cancer, we have enough evidence to use the adjuvant immunotherapy in stage 2 or in stage 3A to resect non-small cell lung cancer. Neoadjuvant nivolumab plus chemotherapy is the choice for stage 1B to 3A the resectable lung cancer. What is the next for immuno-oncology in early stage non-small cell cancer? Medium residual disease is the key tool to build the discretion trial. Perioperative immunotherapy plus the chemotherapy may be an option for the driver mutation patient, but should be explored further. Thank you so much for your attention. Thank you.
Thank you, Yilong, for the very excellent presentation on the early stage and the role of immunotherapy. Now, can I have all my panelists, including Dr. Chua, James, Yilong, and Mingju? So first of all, my apology that I got another meeting coming up, so I will stay until 3:45. And after that, I will ask Dr. Ong to continue the discussion, and because there will be hopefully the more question. So, and also for the audience, if there is any question, please do feel free to type it up so that we can try to address it the best way you can. So, all my dear friends, so let's start our discussion. Why do I just start off with a question on the early stage with Yilong? So interesting data on their preoperative immunotherapy for EGFR or for other driver gene oncogene-driven cancer. But do you think that it's better off to use a TKI in a neoadjuvant setting rather than immunotherapy? I mean, if the objective is to shrink the cancer, why do we have to use immunotherapy rather than a targeted therapy? You know?
Hi, thank you. Tony, so for the immunotherapy, because I just report to the phase 2 trial, that each trial so only the 20 to 30 the cases. So I think so far we have no strong evidence to support the use the IO treatment for the early stage non-small cell cancer. So in now I think for the EGFR mutant patient or the ALK fusion patient, the EGFR TKI, all the TKI had a very high response rate, and also the promise and the long-term survival. So in this situation, I still suggest in this population with the TKI as the neoadjuvant setting. But I think we need further explore what is the real role of the IO in the early stage non-small cell cancer.
Okay, thank you. Mingju, what's your take on neoadjuvant TKI versus immunotherapy for driver oncogene early stage lung cancer?
Well, actually, we don't have any data regarding the chemo IO in the EGFR mutant non-small cell lung cancer. So I think we have to wait for the Checkmate 722 and the keynote to study whether the chemo IO is better than the chemo in TKI failure. So that data might provide some evidence that we can use the chemo IO in EGFR mutant non-small cell. But in general, I think in oncogenic drivers, the TKI is much better than the chemo IO. So I would rather use the TKI rather than the chemo IO. Yeah, that's my.
Okay, thank you so much, James. We got one question for you. The question is: the result from IO monotherapy seem to be different one from another. Is it really different between PD-1 and PD-L inhibitor, or would it be something else related to trial design or the study population? What is your take on the different outcome of some of these IO trials?
Well, I think from all these studies, it's very difficult to compare trial to trial. It's not totally the trial design. It's also pertinent in the timing of performing the study. For example, when Checkmate 024 was performed, that was the only study that aiming to treat this patient and no other competitors. And with, for example, avelumab studies was performed, there has been so many competitors. Therefore, you will encounter that patients who are probably not that suitable to be enrolled in the study was enrolled, or patients who had been on chemotherapy, they do not want to be enrolled in chemotherapy, and a lot of patients got crossover to other agents as well. So with that many confounding factors, it's quite difficult to interpret the data. Remember the first rival of 024 and Checkmate 026, almost identical design, but at the end of the day, 026 got worse patients, and the study ended up as a failure study. So I believe there are many other compounding issues. It's not only the trial design, and we probably cannot figure out whether the drugs are actually different one from the other. But one additional point is that the avelumab do have a shorter half-life, but we also see that with that short half-life, although there are two arms, one is every 2 weeks, the other is every week. at the end of the day, the efficacy seems to be the same. So that means we probably can end up with lower dose in some situation. We probably don't need these ICIs, be continuously present in the blood for a very long time. So there are many questions that we actually do not know.
Thank you so much. Dr. Chua, I actually have one question for you. Now, you mentioned about GEP, which is very interesting, the genome expression profile. However, GEP for one trial is different from another trial. The one that you mentioned in the melanoma, the selection of item is totally different from the other study on lung cancer on choices. So how do we know which is the right quote-unquote GEP profile to use? That when every company promote their own product, but then there is a lack of prospective validation data, how are we going to choose?
Yeah, I think definitely I agree that there's still more study to be done in terms of implementing GEP as one of the biomarker in immunotherapy.
Okay. Do you think that how do you think that we will have a one GEP for all cancer, or do we need to do GEP for one cancer at a time? What is your outlook for the future?
It's hard to answer that question, but I would think that it would be more feasible to have a certain panel of GEP per malignancy, per solid tumor types.
Yeah, that won't be easy.
Yeah.
Definitely. All right. So
and it has to be standardized in some way, because otherwise it will end up with a similar story with the TMB, where the panels are not standardized and the cutoffs are not standardized.
Right. Again. Okay. So, and then there is a question now that, go back to our clinician is about the IMPA 150. The question is that it looked too much complex in the infusion schedule and high chance of adverse event, which I do not agree entirely because it's not too difficult. Do you think there's still a role IO in EGFR mutation positive lung cancer? Now that is a broad question. So why do I get James to start off to kick off of this meeting of this question? Then, yeah.
When we were part of IMPA 150, I saw the regimen. I was afraid, and so were our co-investigators. So we had earlier on some problem with this combination, but once you get used to that, it seems that this combination is feasible. Yes, it does take a long time to administer these drugs, but patients seem to tolerate well. And we did treat much more patients later on, and it seems that once you get used to that, it's a feasible regimen that you can use.
So I have one comment on the ABCP in the TKI failure. Actually, in Korea, we are conducting the phase 3 randomized study comparing the IMPAWER 150 regimen versus the pembrolizumab, the cisplatin in TKI failure. So I think the study readout will be available hopefully next year, end of next year. So I think, as James mentioned, that this 4 drug is quite well tolerable, actually, once get used to. So after 4 cycles of carbotaxol, the beva, and then the patient are quite well tolerable. A little bit of hypertension, sometimes a little bit of proteinuria, but quite well. And so I think we are looking forward to the result. So because the IMPAWER 150, only 10% of the patient are EGFR mutation. So even though the subgroup showed a quite promising result, but it's not the definitive confirmatory study. So we are looking forward to that.
And certainly there is the CheckMate 722, which I will be presenting at ESMO Asia next week. So with that, we got some more insight as well. So just advertisement.
And Orient 031, right?
Yeah. So Tony, I had
Much more coming in.
I had also the one comment also in the Empower 150 based on the Lucian the audience 3-1 tried. I think the 4 drug in the EGR mutant patient. Then resistant. This is a combination. This is a 2 clinical trial. I think this is the work on some of the patients, but not all for all the patients, because the resistant mechanism is so complex. If the EGR failure, we need to the test to find what which is the mechanism. That the CMAT amplify or the another gene the mutation. So we have to choose another drug to treat this patient. But so I think the important issue is when we don't find any mechanism in this situation. So this the 4 drug is work or not. I think this is important in the near future. Yeah.
Right. Yilong, can you comment on the IronPower 151 study in China? Are you involved in the IronPower 151?
IronPower I1?
IronPower 151.
151, yeah. So I think this is in clinical practice. So we are very rare that using this model in the clinical practice.
Yeah. So I guess IronPower 151 is an ongoing study. Instead of Taxol, they use Alimta Cabo in China. And then this phase 3 study actually will be reading out sometime next year as well, I think.
Yeah.
Okay, so should PDL1 and CTLA4 be used in EGFR mutation positive patient? Any opinion?
In the earliest study, that's 012, there was a patient who had EGFR mutation. I think Ipi-Nivo had there were I guess if I remember correctly 4 responses, but at the end of the day these 4 patients all had smoking, and we in 722 there was an arm with Ipi-Nivo, and that arm actually was dropped. Frankly, I don't remember the reason, but I think it's due to lack of efficacy. So, but that part has been forgotten. And I think there were roughly 40-50 patients in the arm. At the end of the day, we still can look at those patients, and it's not very efficacious if it were only for a very short time.
Yeah, I think you're correct, James. We dropped it because actually Ipi-Nivo did not get the first-line indication of the 227. So the BMS decided that may not be of interest for them to develop it in the EGFR mutation space. And we actually get more than that. I think we got 60-some patients in the arm, and then we will provide those data in the future as well. Right. Okay, Mingju, the time is yours. Sorry, I have to rush off to my next meeting. And certainly it's my great pleasure to meet all of you, including Dr. Chua, James, Yilong, and Mingju. And hopefully we can meet soon physically. And indeed, if you're in Singapore, I will be most delighted to meet up with you. So thank you very much. And thanks, BI.
See you next week.
Okay. See you in Singapore.
Yeah, see you. Bye-bye.
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 Bye-bye. So let's go to the next question. So there is questions to the Dr. James Yang. Yeah, the result from the IO monotherapy seems to be different.
Oh, I already answered this. This was due to not only due to study design, due to study timings, due to patients' sites of conduction, competing studies, etc. So difficult to compare to each other.
Right. So I think we should be very careful to head-to-head comparison among the different study. It's very, very careful. So another.
Minzo, Why
Yes.
do you think that we need a comparison for this drug? I think we don't need any comparison for these two drugs.
Right,
Yeah.
that's right.
or you have 30 drugs in China, right? 30 arms.
Yeah.
So I think the current the cumulative evidence suggests that there is no significant difference between the PD-L1 and anti-PD-1 antibodies. So I think as James mentioned, the trial design and study population might affect the different result. So there is another questions maybe to ask Dr. Wu. Is there any difference in registered mechanism of IO in advanced and early stage non-small cell lung cancer?
So far I don't know. Because the adjuvant, the IO, now only the early stage. We need much more the patient and much more the tissue to find the mechanism, the resistant mechanism. But so far, I think that we have no data. But in general, I think maybe something the different because in the early stage we have to know the target lesion. We are only the patient the 2 year the cycle or the 1 year the cycle, and then we know the lesion and we stop the drug. So in this situation, I think the mechanism may be different from the advanced disease. But if they're on the treatment and then the patient be better, the disease progression, I think this is the same as the advanced disease. So that is only the hypothesis. We need the data. Yeah.
Right, and actually, in compared to the other targeted agent, the determination of the registered mechanism in IO failure is quite challenging because the repeat biopsy is not always possible. Yeah. So we need more data. So the next question is, what's your thought regarding the low dose of the immune checkpoint inhibitor in clinical practice? So do you think the Asian patient need different strategy to Western patient? James Yang?
I think the only question is whether we can use a lower dose to save cost. And this has been done for some patients because we know that the appropriate dose may not be known at this moment. We know that even lower dose, there has been at least some responses. So, for example, for Pembro, 200 milligrams each dose. But in the earlier study, there were things like 2 milligram per kilogram or 10 milligram per kilogram that's been used. And all these similar doses seems to be helpful. So if one need to save some cost, I have no, or they tell us exactly that they don't have more money for a higher dose, I have no problem to give them lower dose. But for standard practice, we just follow what's been recommended.
So, what do you think about Dr. Wu?
Yeah, so I think the lower dose may be possible because let's look at the NIVO, the strategies. First, they give the patient the 3 weeks, and then the 4 weeks, and the 6 weeks. But for the 6-week interval, they are also increasing the dose. But I think the mechanism, the IO, the drug, the mechanism is the different from the cytotoxic. I think they don't need, this is not related to the dose because they want to activate the T cell activity and then the dependent T cell to kill the cancer cell. So in this point, I think lower dose, middle dose, or higher dose. That is possible. But now we are only the according guideline. We need more data. But in clinical practice, if the patient after the 2-year cycle, in clinical practice, I always delay the patient, such as from the 3 cycle to 4 cycle. This is our clinical practice.
Okay. So we have only 4 minutes left. So we're gonna have only 2 another questions. What would be the optimal IO for PD-L1 less than 1%? James Yang?
I guess there are 2 options. One is to use a combination with chemotherapy. The other is to use ipi-nivo or 4 combined, right? These are the one that has data.
I agree with James. So the combination with the IO, the chemo, but in clinical practice for PD-L1 less than 1%, we prefer the 9LA model.
So Dr. Chua?
9LA, the 9LA, treatment 9LA. That means the IO plus the EP, the nivo plus the EP plus the 2 cycle the chemotherapy.
Okay. So Dr. Chua, given the PD-L1 expression, with your experience, do you think the Asian patients have more PD-L1 negative than the Western?
Based on our collated data, our data shows that we have good correlation with the Western data population. So it's about 30% less negative, 30% low positive, and 30% about high positive. We do see occasionally in the outskirts in the provinces where they complain about a higher negative PD-L1 rate, but we think it's mostly due to pre-analytic factors in testing.
Okay.
Not real tumor biology yet. Okay.
So Dr. Wu, so who's gonna benefit from the IO adjuvant?
Yeah, so far we have the only one trial approved by the FDA. This is the Imparo 010. So we all the data from this clinical trial. First, I think the patient stage 2 or the 3A. This is the benefit. The second, the PD-L1 the PD-L1 positive, expand positive. So I think these 2 the factors can benefit from IO. But actually, when we are tested to look at the Imparo 010 data, only the PD-L1 more than 50% patient get the benefit. So in clinical practice, I only use the PD-L1 more than 50%, and then the stage 2 or stage 3A the DE to receive the adjuvant IO.
Mm-hmm. Okay, so this will be the last questions. So maybe to the James Yang. So there is always the question about the PD-L1 high patient, whether we should use the IO mono, IO combo, or IO chemo combo.
Good question. Difficult to answer. For patients who is not urgent, meaning that small tumor volume seems to be not good performance status, etc. I tend to use IO mono because this is only reimbursable agent. Or IO chemo is not reimbursable in Taiwan. But for patients who had probably bigger tumor burden, and it seems that if they don't respond, they will just die or have no second chance, I will use IO chemo. So that is my criteria.
Okay, great. So I think we are almost done, and I would like to thank all the speakers for excellent lectures and all the the good answer for the Q&A, and then I also thank for participant for giving the questions. So actually we are behind the schedule, so we don't have, we're not gonna have the coffee break. So we're gonna proceed to the next session. And then I would like to hand over to the Dr. Michidomi. Thank you.
Hi.
Thank you.
Thank
Bye-bye.
you so much,
Okay.
everyone. So yes,
Thank
in the
you.
interest of time, we will go straight into discussion number 4. However, for those of you on site with us, still feel free to take the tea and coffee outside of the room at your own time. So moving into the final discussion, this is on emerging treatment landscape of targeted therapy in NSCLC, chaired by Professor Mitsudomi. Over to you, Professor.
So without coffee breaks, I'd like to proceed to discussion 4. The first speaker is Dr. Jian Van Di. He's a joint appointment professor of the Institute of Medical Science and Technology at the National Sun Yat-sen University in Taiwan. And he's going to talk about the evolving landscape of biomarker testing for non-small cell lung cancer for targeted therapy. So unfortunately, he's not available here, but we'd like to hear his lecture.
Good afternoon, dear all. I'm Junfen Li from Qingmei Medical Center and also the National Institute of Cancer Research, NHRI, Taiwan. It's truly my greatest honor in here to share some concepts related to the evolving landscape of biomarker testing for non-small cell lung cancer or targeted therapy with all you. This is my disclaimer. It's becoming challenging to profile drug-borne mutation in non-small cell lung cancer. To that, we have to see a list of genes in this tumor type. Of these, some are common mutations, such as EGFR, exon 19 deletion, etc. However, some mutation types are uncommon. For example, the EGFR exon 20 insertion, KRAS G12C, and MET skipping, etc. And even there are some mutations which are quite rare, such as NTRK fusions. So, as mentioned earlier, it becomes very challenging to profile all these genes within the test in daily practice. For example, in Taiwan, the reflex test is as such. We perform EGFR real-time PCR test as the first-line test, and if EGFR testing is negative, we can perform OAK testing, and if the OAK immunohistochemistry is negative, we can perform PD-L1. And ROS1 staining or real-time PCR testing can be performed together with OAK staining. We learned that there are more genes should be tested. For example, the MET, RET, NTRK, BRAF, KRAS, and HER2. And even for KRAS mutation, the exon 20 insertion could be missed by the first-line EGFR real-time PCR. So now we learned that we have to add some tests for the EGFR exon 20 insertion, for example, real-time PCR or single sequencing. And if we try to profile non-small cell lung cancer genomic alteration, in every case, there must be some barriers. From a questionnaire study conducted by ASCO, there are some barriers for comprehensive or multi-gene biomarker study. The most important barrier is the adequacy of tissue samples, and followed by the testing time, the waiting of the results. So the most critical reasons for not ordering biomarker testing are inadequacy of tumor sample as well as the waiting time. As for the waiting time, in that study, most respondents consider 1 hour or 2 hour turnaround time as acceptable. However, as we know, it's not possible to always complete a multi-gene test in 1 week or 2 weeks. So it suggests that we should have some alternatives aside from NGS tests. Another reason that we should have other tests other than NGS is that from the experience of LC's ground, for the NGS test, there are a high frequency of DNA and RNA inadequacy, as shown here. In contrast, if we use real-time PCR, such as AMOI 9-in-1 assay, the tissue unsatisfactory rate is much lower than that of NGS tests. Actually, for a molecular test, successful rate is very critical to a clinical. And accordingly, now we have more choices for the comprehensive or multi-gene profiling. If you want to have a very comprehensive result regarding all genes tested, you can perform NGS. Better to be DNA-based NGS for mutation profiling and RNA-based NGS for the fusion test. On the other hand, if the tissue is not qualified for NGS or the time is very limited, multiplex real-time PCR could be the good method for genomic profiling. For example, if you use amyloid lung cancer panel, you can test a list of genes, including 11 genes, in a set of tests, including DNA tests for EGFR, BRAF, KRAS, ERBB2, and the RNA tests for fusions of ORC, ROS1, MET, RET, and NCHEX. It's really time-saving and also less costly, and you can also save the patient samples for further molecular analysis. So based on limited experience, I enjoy using this assay very much. And here I would like to share with you a story that within the past 3 months, I tried to profile so-called EGFR or ROS1 pan-native adenocarcinoma of lung by using amyloid assay. So I accumulate more than 100 of such cases, and I will show you in the EGFR, ORC, and ROS1 pan-native cases, what can we see by using amyloid PLC panel? By using this assay as an adenocarcinoma, mucinous adenocarcinoma. Based on its morphology feature, I consider it might be a KRAS mutation tumor. And luckily, we have that assay, which precisely identifies KRAS G12C mutation in this sample. This is a biopsy sample, some biopsy codes in which you can see epithelial components forming abortive glands, and there are some spindle cells and some are bizarre, as shown here. So it's a typical polymorphic carcinoma, as shown here, adenocarcinoma, spindle cells. It's a tumor of MET exon 14 skipping. And because the rarity of the genomic alteration, we also confirm the findings by using NGS. And this is a lobectomy sample as bronchus and surrounding bronchus are a squamoid-like area, and there are some mucin producing adenocarcinoma. In the lymphadenoma, it's a adenocarcinoma with mucin production. It's a tumor involving a young lady, non-smoker. The initial tests, including EGFR, ROS1, and PD-L1, are all negative, so I consider there might be some driver events. Luckily, the PLC assay identified HER2 exon 20 insertion, and we also confirmed the single sequencing, confirmed the findings by single sequencing. And from a transbronchial lymph node aspiration biopsy, you can see there are many blocks here and scattered tumor nets as shown here. From the scanty tumor tissue, we identified EGFR exon 20 insertion. And for the EGFR exon 20 insertion as well as the HER2 insertion, we routinely perform the sequencing as shown here to identify the insertion patterns, because not all insertions should be treated in the same way. So we use to do that to confirm the insertion type, the sequencing. And we will report that as the addendum of the reports. And it's a prior metastasis. The tumor is clearing, scattered with in a fibrotic background. From the PLC assay result, we learned it's a tumor of red rearrangement. For clinical trial or some therapeutic purpose or drug application, we have to detailedly report the fusion type of red. So we routinely performed NGS for that. In this case, we identified it's a typical KIF5B and a red gene fusion, beautifully illustrated. And interestingly, for the 110 EGFR or ROS1 pan negative adenocarcinoma of lung, almost one half of these cases can be identified to harbor driver, and most of them are druggable, including EGFR, exon 20 insertion, and KRAS G12C, BRAF, and surprisingly, the most frequent red fusion. And if there are some combined mutations as shown here, and I would like to show you that some of them are common EGFR mutations, such as EGFR exon 19 deletion, as shown here. So this assay is highly sensitive to detect these common events as well as the uncommon events. So based on my practice, including those involving the so-called pan-native lung cancer or use PLC as first-line test, my suggestion is that if you use multi-gene PCR assay, and if the result is positive, and it indicates the presence of common drivers, you can report the results. And if the result is uncommon drivers, you better to perform sequencing, including NGS, to validate the results. And if the result is active, suggest a patient to go to qualified NGS. That is because, especially for the treatment resistant case, there might be some gene amplification, deletion, or there might be some uncommon fusion partners that are not included in the PLC assay. And there might be some relevant mutations involving such as MARK-A4, and sometimes you should know complex biomarkers and additional clinically relevant mutations. So it's my last slide. There is no single best methods, but we can combine various methods. Most convincing result for patients. And real-time PCR is a good method to use via first-line genomic testing. Thank you so much.
Thank you very much. So next, I'd like to invite Dr. Minju An from Samsung Medical Center. So she's now talking about what's new for the treatment targeting antibody-drug conjugate in non-small cell lung cancers. So please start.
So I'd like to thank Orange Committee for inviting me to this symposium. I'm going to talk about the antibody-drug conjugate in non-small cell lung cancer. These are my disclosures. During the last 2 decades, rapid evolution has been made in the treatment of non-small cell lung cancer with targeted agent immune checkpoint inhibitor. However, most of the patients develop a resistance and a limited treatment option. So currently, antibody-drug conjugate as part of chemotherapy provide new treatment options. Antibody-drug conjugate consists of antibody, linker, and payload. Antibody should bind the target, which is highly expressed on tumor, but low on normal tissue, and should have a longer half-life and low immunogenicity. The linker should be stable in circulation and efficient release of payload. And the payload should be potent, amenable linker attachment, having local bystander effect and acceptable off-target the toxicity. This cartoon demonstrates the mode of action of ADC. First of all, ADC circulates in the blood and bind to the target, expressed on the cell membrane, followed by internalization, and then linker and payload are released from the antibody. The payload going to the nucleus, leading to the cell death. In general, compared to the traditional chemo, ADC has a more favorable therapeutic index and minimal side effect because of the specific binding to target protein, but duration of effectiveness may be limited. Currently, a lot of ADC are being investigated in non-small cell lung cancer. Several selected ADC include ADC target HER2, HER3, TROP2, CEACAM5, and CMAP. This table shows the several third-generation ADC under development. As you see, each ADC has different targets, linker, payload, and drug antibody ratio. So efficacy and toxicity are variable according to these components. So let me discuss the clinical trials result of each agent in non-small cell lung cancer briefly. TDM1 is the first HER2 targeting ADC approved in breast cancer, and the TDM is also investigated in non-small cell lung cancer. However, in overexpression HER2 protein, the TDM1 did not show any significant promising result. In contrast, objective response was 44%, 5 months of PFS in HER2 mutation. So next generation HER2 targeted ADC, trastuzumab deruxtecan, TDXD, has different linker and payload from the original TDM, but the same antibody, the trastuzumab. So TDM1 is a high drug antibody ratio around 8, and stable linker payload and tumor selective cleavable linker, and high potent membrane permeable payload, leading to the bystander killing effect. So one of the distinct characteristics of TDXD is compared to TDM1, it has a membrane permeable payload, so leading to the bystander killing effect to the surrounding antigen negative cells. TDXD is the second FDA-approved ADC for HER2 positive breast cancer and also gastric cancer. As you see, recently, TDXD significantly improved the PFS and overall survival, even in HER2 low breast cancer, resulting in treatment paradigm change in breast cancer. So these results lead to the investigation in non-small cell lung cancer. So Destiny Lung 01 investigate TDXD in HER2 overexpression or HER2 mutant non-small cell lung cancer. HER2 mutation is observed in 3% in non-small cell lung cancer and usually a younger female, never smoker, and usually the poor prognosis and the high incidence of brain mets. So far, there is no approved HER2 targeted therapy in non-small cell lung cancer. In Destiny 01, Lung 01, first of all, the cohort 2 and expansion cohort, HER2 mutant non-small cell lung cancer were treated with 6.4 milli per key of the TDX every Q weeks. The primary endpoint was overall response rate. As you see, among the 91 patients, median age was 60, 65% are female, 36% have CNS metastasis, 57% are never smokers, and 98% are heavily treated with chemo or plus platinum chemotherapy. As you can see, the most of patients showed a marked shrinkage of tumor, and objective response was 55%. Median duration of response was 9.3 months. Response was observed across many different types of HER2 mutation, and also no detectable HER2 expression or HER2 gene amplification. PFS was 8.2 months. Overall survival was 70.8 months. It's quite a striking result. The most common adverse events were nausea, the fatigue, neutropenia, anemia, but grade 3 adverse event is mostly less than 8%. Interstitial lung disease, one of the unique the side effect for the ADC, which occurred 26%, and 2 patients died of the ILD. And then most of the ILD are grade 1 and 2, and managed with the corticosteroid. So based on this data, TDXD were approved by the FDA in 2020 in HER2 mutant non-small cell lung cancer. Let me share my case. The non-small cell lung cancer who resected, and this patient has EGFR negative, PD-L1 was negative, and the NGS showed a HER2 mutation. So this patient was treated with TD1 after. So you see the multiple lung-to-lung meta and mediastinal lymph node. After 2 cycles of treatment, marked shrinkage of the lung mets and the lymph node. So Tropion pan tumor 01 is a first in human study of the Dato-DXd for advanced solid tumor. The Datopotamab, the Ruxtecan is a TROP2 targeting ADC. So TROP2 is expressed in the 64 to 100% of the lung cancer and 75 to 92% in squamous lung cancer. As you see, the TDXD composed of a TROP2 antibody and the same linker and payload to the TDXD. So Tropion-Pan, the tumor 01 is a first in human study. And after dose escalation, in dose expansion, cohort in non-small cell lung cancer, patients were treated with 4 milli per key or 6 milli per key or 8 milli per key of the Dato-DXd every 3 weeks. The most common adverse event, quite similar, the nausea, vomiting, fatigue, anemia. Adverse event are manageable, but it seems that grade 3 related advance is more high incidence in the increased dose of Dato-DXd. And the dose interruption or dose discontinuation, dose reduction is more common with increased dose. And the ILD was observed in 6 to 14% of the patient across the different doses. The waterfall showed a quite impressive tumor shrinkage. Objective response was 24% for 4 milligram, 28%, 6 milligram, 24% for 80 milligram, so suggesting quite a similar response rate across different doses. So the consideration of a low rate of discontinuation rate and the side effect and the efficacy, 6 milligram per key, those were selected for the development. So one of the interesting findings is that Dato-DXd also has a quite promising anti-tumor activity in patients with genomic alterations. So among the 34%, so 85% have the EGFR mutation, 9% ARC, 3% RAS1, 3% RET fusion. As you see in the right panel, clinical activity was observed in EGFR mutation, ARC, and other alterations who failed the prior TKI. The response rate was 35%. The median duration of response was 9.5 months. So given the limited treatment option for this group, these results are quite encouraging. So I'm going to share one case, 36 male, 5 PEG year. This patient initially diagnosed is non-small cell lung cancer and the metastasis to the bone and the brain and the liver and the stage 4 disease. He has initially EGFR ARC was negative, NGS was negative, PD-L1 0%. He was treated with chemo IO, but progression. So he received a TROP2, 6 milligram per key. And actually, I did the NGS again, and NGS revealed the ARC fusion. So this fusion, this patient, after the 2 cycles of TROP2, as you see, the lung metastasis was marked shrinkage, but bone mets was showed a stable disease. Another TROP2 ADC, sacituzumab, govitecan IMU-132 is being investigated. IMU-132 has different TROP2 antibody and different linker, and SN38 is a payload, which is 136 times more potent than the parent compound irinotecan. This payload is also membrane permeable and considers a bystander effect. In phase 1/2 study, pre-treated non-small cell lung cancer, patients were treated IMU-132, 80 milligram per key or 10 milligram per key, day 1, day 8, every 21 days. Among 34 patients, objective response was 90%, duration of response 6 months, and more than 90% of tumor were high positive TROP2. Median PFS was 5.2 months, overall survival was 9.5 months. So in this study, IHC assessment of the TROP2 expression was performed, whether this expression is used for the biomarker. However, as you can see, it doesn't seem to any correlation between TROP2 expression and clinical response. The next, patritumab deruxtecan is another ADC targeting HER3. The DXD composed of patritumab HER3 antibody, same linker and payload to TDXD. So EGFR mutant non-small cell lung cancer associated with high expression of the HER3 compared to EGFR wild type. So given their broad expression of HER3, this membrane protein provides an attractive target for the EGFR mutant non-small cell lung cancer. Multicenter phase 1 was conducted in non-small cell lung cancer with EGFR mutation. Patients were treated with 5.6 months per key of HER3 TDX every 3 weeks. The objective response was 35% in patients who failed prior platinum-based chemo and osimertinib. Time to progression was 2.7 months. Duration of response was 7 months. It's quite a promising result, and the median PFS was 8.2 months. These responses were observed regardless of different resistant EGFR mutations, such as T799, C79S, or others. In the lower panel, the response was also observed in patients with non-mutation or fusion. And also the clearance of the ctDNA after HER3 DXD was associated with higher response and longer progression-free survival. So this patient, the 57-year-old female, never smoker. The patient have the stage 4 metastatic to the pancreatic, pleural, liver, brain. She has exon 19 deletion and received gefitinib, osimertinib, and then amivantamab, and then chemotherapy. So heavily treated the patient. So this patient was treated patritumab. And as you see, large right lower lobe mass and intra-abdominal lymph node and brain mass after 2 cycles, these tumors are marked shrinkage, showed quite promising the result, and this patient treated more than 1 year. Tuzamitamab ravtasin is ADC targeting CEACAM5. CEACAM5 is also overexpressed in multiple malignancies in the lung cancer. And in this study, DM4 tubulin inhibitor was used as a payload in the SAR ADC. In phase 1 study, 100 milligram per body square meter every 2 weeks were defined as MTD, and 2 different cohorts as expansion were investigated in non-squamous lung cancer with the CEACAM high expressor or moderate expressor. The objective response was 20% for high expressor versus 7% for moderate expressor, suggesting CEACAM expression might be the predictive biomarker for the response. The most common adverse event were the fatigue, diarrhea, loss of appetite. One of the distinct side effects were keratopathy or keratitis, which observed in the 38% and grade 3 adverse event 10.9%. These adverse events were reversible by dose reduction or interruption. Finally, telosotuzumab vedotin ABBV-399 is ADC targeting MET. The MET amplification or expression is one of the resistant mechanisms to EGFR TKI. In the study, patients who have the high MET positive non-small cell cancer assessed by the immunohistochemistry were enrolled. MET high expression was defined in non-squamous lung cancer as the 25% and 3 positive by immunohistochemistry, and for squamous, 75%, 1% by immunohistochemistry. And EGFR mutant or EGFR wild type non-small cell lung cancer with a c-MET high or intermediate expression were treated with 1.9 milligram per kg of Talisor every 2 weeks. In EGFR wild non-small cell lung cancer, the objective response was 52% for high MET and 24% in the c-MET intermediate. In contrast, in EGFR mutant non-squamous, objective response 16.7% for c-MET high expression, but 0% in c-MET intermediate. In the squamous, the objective response rate was 11%, suggesting high MET expression might be the predictive biomarker. The most common side effect, nausea, fatigue, loss of appetite, and hypoglobulinemia, and hypoalbuminemia, peripheral neuropathy, and peripheral edema is usually associated with c-MET inhibition. But the grade 3 is only 4% for the sensory neuropathy. So based on the promising result of the each of drug in phase 1/2 trial, all these drugs are being investigated in randomized phase 3 trials. So as you can see in the table, a lot of the clinical trials are ongoing as a first line and second line. So we are looking forward to see the final result of these trials. So in conclusion, the patients who progress on chemo-IO or targeted agent have a very limited treatment option, and their prognosis is very poor. These novel agents have been designed with different payload, linker, drug to antibody ratio technology to improve the efficacy and tolerability. Some require pre-screening for the gene mutation or protein expression, but others are unselected. So many promising results are observed, and the phase 3 studies is ongoing. So adverse events include nausea, vomiting, cytopenia, neutropenia based on the payload, ILD, pneumonitis, or corneal adverse events, also variable according to the payload. And the CNS activity is more investigated. So finally, the combination approach to maximize the outcome and to optimize toxicity is required. Thank you for your attention.
Thank you very much. Very comprehensive talk about ADC drugs for non-small cell lung cancers. So next, I'd like to invite Dr. Sang-Wei Kim. And he's a professor of internal medicine and medical oncologist and the chief of department of hematology and oncology at some medical center. And Professor Kim will talk about HER2 and the exon 20, EGFR exon 20 mutations. So please start.
Good morning. I'm Sang-Wei Kim from Assam Medical Center, Seoul, South Korea. It's my great pleasure to talk about HER2 mutated non-small cell lung cancer for Vietnamese Cancer Society. This is a disclaimer. And this is my disclosures. As you know, HER2 is one of her family tyrosine kinase receptor gene or gene product. HER2 does not have known soluble ligand, but its downward signal change is triggered by dimerization with other ligand-bound her family members. The consequence is receptors hyperactivation. There are three distinct HER2 activation mechanisms in non-small cell lung cancer: amplification, mutation, and overexpression. And these alterations are not strictly associated with each other, and the tumors with each alteration have different clinical characteristics. Today, I will focus on HER2 mutation, and the prevalence is about 3% of non-small cell lung cancer. 90% of meaningful HER2 mutations are in exon 20 as insertions of amino acids. And exon 20 is responsible for alpha C helix and the following loop. And such amino acid insertions in exon 20 causes constitutively active conformation of HER2. Unlike EGFR exon 20 insertion, is rather homogeneous, and the most common insertions are YVMA, VC, and GSP amino acids. So, for patients with HER2 mutated non-small cell lung cancer, we can consider three types of targeted treatment strategies: TKIs, monoclonal antibody photoreceptor, and antibody drug conjugate. I will present some details of TKIs and ADC today. In the data from CBio portal for cancer genomics, insertion of SMID amino acids, YVMA, VC, GSP, make up for most of HER2 exon 20 insertions. So, a Japanese group tested the in vitro sensitivities of panel inhibitors against these three alterations after transfection of these insertions into cell lines. They compared the sensitivity with the selectivity index, which is defined as the proportion of IC90 of human drug concentration at the recommended dose. Higher dose means relative insensitivity. As you can see, the index was higher in the cell line with YVMA insertion across all panel inhibitors. And one exception was poziotinib, a relatively novel TKI at that time of experiment. So when they reviewed some reported cases, usual panel inhibitors such as apatinib, dacomitinib, and neratinib showed poor responses for YVMA inserted tumors, which is more prevalent compared with the GSP insertions. Non-selective panel TKIs did not produce good results. In global MPU or phase 2 studies with afatinib, the response was only 19 or 0%. Dacomitinib, 12%, neratinib, 3.8% of response. While HER2 exon 20 insertion induced constitutively active conformation, YVMA insertion induced a shift of P loop and alpha helix into drug binding pocket, thus reducing the size of drug binding pocket. Poziotinib is a relatively small size TKI, could overcome this hindrance. Pyrotinib is another small size panel inhibitor. In phase 2 study, poziotinib produced 27% of response, 73% of disease control rate with a 5.5 months of PFS. The drug was rather toxic and showed a 47% of grade 3 rashes. To manipulate the poziotinib's toxicity, Genesis 24 trial compared 16 mg QD dose versus 8 mg BID regimen. In this year's ESMO presentation, BID regimen still produced 79% of dose interruption and 64% of dose reduction rate. So poziotinib did not meet the expectation due to safety profile limitation. Pyrotinib is another small-sized panel inhibitor from China and produced 30% of response with 6.9 months of PFS. Safety profile showed no grade 3 rash, but 20% of grade 3 diarrhea. This drug is currently under phase 3 trial. Mobocertinib is an ATP mimetic TKI structurally designed to more selectively target EGFR and HER2 exon 20 insertion. Preclinically, it showed activity against 2 gem models, while bad results with the VC insertion type. It is on the clinical trial, waiting some results. Taroxetinib is an interesting prodrug that harnesses tumor hypoxia to generate high level of potent covalent pan-HER inhibitor within tumor microenvironment, which means it was designed to circumvent EGFR skin and GI toxicity. As expected, the drug showed a lower rate of skin and GI toxicities. In cohort 2 trial of RAIN-071 for HER2 exon 20 insertion non-small cell lung cancer, 2 out of 9 patients produced objective response. Until now, the big hurdle to develop HER2 inhibitor has been its EGFR-related toxicities. So we need to develop more selective drug. When a new HER2 TKI is regarded as selective, it should display more than 50 times of wild-type EGFR sparing activity. BI 1819631 is one example which can spare wild-type EGFR. While sparing wild-type EGFR, it can block most HER2 mutation, including wild-type HER2. Now, I will call it BI drug. In preclinical experiment, BI drug showed activity comparable with poziotinib. This is a phase 1 study design of BI drug against solid tumors with HER2 aberration, including dose expansion cohort for non-small cell lung cancer. In last AACR-NCI EORTC conference, the early results were presented. Of the 29 participants, 62% were patients with non-small cell lung cancer. This is a swimming plot of patients continuing BI drug. The orange color represents cases with non-small cell lung cancer. In case of non-small cell lung cancer, objective response was 50% and the disease control rate was 93%. For 17 patients with the BID dose, only 1 patient showed grade 3 treatment-related AE and dose reduction, and it was increased ALT. For 12 patients with the QD dose, only 1 patient showed grade 3 anemia without dose reduction. Trastuzumab deruxtecan is an antibody drug conjugate composed of 3 portions: antibody, link, and cytotoxic payload. The link is stable during circulation. When the drug binds to HER2 positive tumor cells, it enters the cytoplasm through endocytosis and cleaved by lysosomal enzyme and released cytotoxic payload. Deruxtecan is a topoisomerase 1 inhibitor and 10-fold potent compared with the active metabolite of irinotecan, and it has a higher drug to antibody ratio compared with other ADC such as TDM1. Destiny Lung 1 phase 2 study hoped to assess the efficacy and safety of trastuzumab deruxtecan with HER2-mutated non-small cell lung cancer who had relapsed on or were refractory to standard treatment. 91 patients were enrolled, median age 60, female 66%, and Asians 34%. Most mutations were in kinase domain and 6.6% in extracellular domain. This waterfall plot is showing the degree of tumor shrinkage, and the response were observed across HER2 mutant subtypes, and it was regardless of HER2 overexpression or amplification. 53.8% objective response, including 1 CR. This control rate was 92.3%. Median duration of response was 9.3 months. 8.2 months of PFS and 17.8 months of OS. Grade 3 drug-related AE were observed in 46%. The most common drug-related AE that caused dose reduction was nausea and fatigue. The most common drug-related AE that caused treatment discontinuation was investigator-reported pneumonitis and ILD. In addition to the previous AEs, adjudicated drug-related interstitial lung disease occurred in 26%. The median time to onset was 141 days with 43 days of median duration. Mostly grade 1 or 2, at the time of data cutoff, it is reported that 54% of all patients had fully resolved. In summary, HER2 alteration, including HER2 exon 20 insertion, is another important target of non-small cell lung cancer. Unlike EGF exon 20 insertions, HER2 exon 20 insertions are rather homogeneous, and the YVMA insertions was the most prevalent one. I presented the status of panel inhibitors, including HER2 selective drug and trastuzumab deruxtecan. Thank you for your attention.
Thank you very much. Now, I'd like to invite the final speaker of this meeting. So Dr. Terufumi Kato is from Japan. He's currently the chief physician of the Department of Thoracic Oncology of Kanagawa Cancer Center in Japan. So Dr. Kato will talk about MET exon 14, skipping mutation, MET amplification, and the KRAS mutations. So Dr. Kato.
Thank you for kind introduction, Dr. Mitsudomi. I'm nice to stay here again. Chao Moi Goi. Thank you very much for staying until this night, this afternoon. And I also thank to the Boehringer Ingelheim, Germany company. I'm afraid Japanese football team won 2 days ago, but today there's no Germany people, so I can feel free to talk about that. Thank you very much. And today I have to say 3 kind of topics. One is what going on in Japan, especially for the MET and KRAS. Okay. Well, this is disclaimer, disclosures. Oh, go back. As you all know, in your left, very tasty pie chart. Various and delicious the cakes you look like. But do we need to remember all of them? It's very difficult. And Dr. Lee have shown the Amoy, the multiple PCL is very useful. And Amoy was just approved in Japan for the patient with lung cancer. And this data is from the LC Scrum Asia. And I hear Vietnamese, some hospitals will join LC Scrum Asian Pacific. And this PCL-based multiple testing takes just 2 or 3 days to check all the mutation alterations. But of course, commercially, it takes a little bit more because we have to send our specimen to the lab, and we need to somewhat. So around 1 week is enough to get the final result. So before the Amoy testing was approved in Japan, the rate of the multiple testing using Amoy and using Oncomine around 50% of the patient. But afterward, the Amoy was coming, and many doctors, many patients want to be tested by the multiple testing by PCR. So now I hear around 70% of the patient now check the genetic status just before the starting of the first line treatment. So the precision medicine oncology is now in practice in Japan. But still, we have to remember many gene alterations. So I propose you some how to remember. Do you know Ma-kun? Maybe if you're the fan of the baseball, the Masahiro Tanaka is very famous player, once played in New York Yankees, and he returned to Japan, Rakuten Sendai Eagles, and he was kind of a legend player in Japan. So we call him Ma-kun in Japanese. So ever Ma-kun on 20 channel. Do you know what I mean? I don't know. just the complex phrase of the EBAR-MRKN and 20 CHM. E represents EGFR, B BRAF, ALK, ROS1, MET exon 14 skipping, RET, and KRAS and NTRK. This 8 gene alteration is now we have to check because each driver have each own drug, and now we can prescribe because all of the drugs is already approved in Japan and also reimbursed. And 4 other one, EGFR exon 20, CLIP1, LTK, HER2, and NRG1. These are on development still in Japan. So ever Ma-kun, we have to remind in mind. And 220 channel is if you have a chance to be checked for the patient, please send. I always ask the doctors to send the patient to the kind of our cancer center because you have a trial for them. So, but it's not Vietnamese. Please make your own word for that. And now I'm start with MET. Maybe you all know the name of the MET, but MET is very old-fashioned name, and then different from the previous EGFR, organ, and so on. What is the biggest difference between the previous oncogenic drivers? The MET protein have juxtaposed domain, and it is coded by exon 14. So maybe you will know, exon 14 skipping will result in the lack of juxtaposed membrane domain. If the deletion or some point mutation were visible in the DNA, in a splicing process, the exon 14, exon 14 itself disappeared in splicing. Then in your right, you can see the protein lack of juxtamembrane domain coded by exon 14. And what the problem for them? Juxtamembrane domain is very important to recycle of the protein. The MET protein, it have signaling internally, but if the exon 14, the juxtamembrane domain was lacking, the MET protein stays longer than usual. Then the proliferative signaling continue. So it will be resulted in oncogenic or sometimes much like the cancer. And we have already tried 2 types of the inhibition of the MET exon 14 skipping protein, but mainly we have a TKI called crizotinib, tepotinib, and capmatinib. And nowadays we have another data from antibodies called amivantamab. The crizotinib is first the evidence we had, but no, crizotinib is for the ALK, but this was originally designed to inhibit the MET itself. During the MET development, the ALK mutation, ALK fusion was found, so Pfizer decided to try it, and some of the patients shrink their tumor. So the ALK is their first oncogenic alteration for the crizotinib, but actually this was designed for the MET inhibitor. But for the MET exon 14 skipping, overall response rate is just 32, a little bit lower than expected. And more selective design called tepotinib and capmatinib come up later. And tepotinib data for the response rate is around 50. And if you give the first line setting more than 60, and duration response is like 1 year or more if you give in the first line setting. So tepotinib is available in some country, including Japan. Another one is capmatinib, very similar. When we give the capmatinib for the first line setting, the overall response rate is around 60-70, and duration of response is around 1 year. Now, we don't have improvement of the amivantamab for the patient with exon 14 skipping, but this data is very fascinating because response rate is just 33, but most of them are already failed to the previous tepotinib or capmatinib or crizotinib. So this, I am estimating that maybe this drug could be the second targeted drug for the patient with MET exon 14 skipping, I guess. So far, FDA, EMA, and Japan, the Japanese PMDA approved 2 capmatinib, tepotinib. In Japan, because there is some reason of the companion diagnosis, most of the patients with exon 14 skipping was treated with tepotinib. Tepotinib and capmatinib have unexpected side effect called edema. So now we are facing how to reduce the edema for the patient. Then maybe that from the study, from the experience of the afatinib, we know that reduction of the dosing is very effective for the patient. So it's same for the patient with edema by the MET exon 14 skipping inhibitors. So anytime we see the patient's edema like leg or arms, and sometimes in the body, we will recommend them to discontinue for a while, then reduce the dose. It's our practice. And following exon 14 skipping, already today we have talked about the MET amplification after the osimertinib first-line treatment. And in your right, maybe 5 to 10% of the patient have MET amplification after the giving of the osimertinib. And the newer trial was just presented in the recent conference, the ESMO in Paris. Then inside 2, it is the using tepotinib and osimertinib after failure of the osimertinib itself. After osimertinib, adding tepotinib, response rates around 50, incredibly. And of course, the patient tend to have leg or arm edema also, same as the exon 40 skipping. But we know how to reduce them. Then maybe soon these data will be more better because we know how to manage the adverse events so far. Okay, here is the short summary for the MET. Among various MET gene alteration, exon 40 skipping is proved to have benefit by the MET-selected TKI treatment. TEPO or capmatinib should be given for the first-line setting of the patient who have proved to have exon 40 skipping mutation. Acquired MET amplification is one of the most important resistant mechanisms for after the osimertinib or some other TKI for EGFR. Maybe clinical trials of combination strategy is now going, and maybe 2 or 3 years ago or later, the newer data will come up. Okay, let's move on the RAS, especially KRAS. And Dr. Mitsudomi have already talked about the long history of RAS. Maybe some of you studied what RAS means, Laus sarcoma virus. And we know now it is, we should regard to be the oncogene. But it was very long history. It was very difficult to find the good inhibitor for the KRAS positive patient. Here, you can compare what's EGFR going on and what's going on in the KRAS. The KRAS gene is, KRAS protein is only one protein in lung gene alternative drugs because KRAS is not located on the membrane. KRAS protein is in the cytoplasma. So the intracellular KRAS protein is moving every time, so difficult to catch it up. And it uses GTP. In EGFR, they use ATP, but GTP is more and more very abundant in the cell cytoplasma. And finally, most important thing is the KRAS proteins is like a ball. So, moving and then difficult to find. And if maybe you all know, EGFR have ATP binding site inside the membrane, but on the contrast, the KRAS gene have a very small notch for the GTP binding site. So it is very difficult to make small molecule to inhibit the connection with the KRAS protein and GTP. So it was very difficult to find a good drug. But around 10 years ago, allosteric effect was found. Allosteric, do you know what that means? Actually, I didn't. Allosteric means like a Mazinger Z or Evangelion, the big like monster, but it doesn't work. If the driver come up here, then it will move. But allosteric means you don't need to move directly or connect directly to the GTP binding site. Just block like adagrasib or sotorasib, touch the other part of the GTP binding. So then they will change the formation. It is called allosteric effect. And there are 2 drugs, including adagrasib and sotorasib. Very similar efficacy. But a little bit apart from the other oncogenic drivers, inhibitors, sotorasib and adagrasib, response rate around 40, less than 50. And finally, PFS is around 6 to 7 months, a little bit shorter than EGFR or ALK and so on. So these KRAS G12C inhibitors focus on the second line so far. And Cohibrec 200, Cohibrec 200, we didn't have Cohibrec, no, Coldbrec, sorry. Coldbrec 200 phase 3 design was just presented in Paris and comparing the sotorasib versus docetaxel. As you can see, the down in rate it's similar, but down how strongly down the shrinking size is really different. In new left sotorasib, the median number of the duration is around 60% of the tumor, 60% tumor size, compared to the around 50 to the docetaxel. And response rate is completely different, 13% for docetaxel versus the sotorasib, 28, around 30. A little bit lower in numerically compared to the phase 1 study, but this was enough for the second line setting. So the PFS is longer enough. Hazard ratio was 0.66, and the median PFS was longer in sotorasib if you gave him. So far, the sotorasib and adagrasib result is not enough to go standalone for the monotherapy for the first line setting. So now we have many approaches combining some drugs or to find other kind of the inhibitors. The CYP2 or SOS in your red circle, these are the kind of the key genetic points to combine with the KRAS drugs. So, but in Japan, we don't have that kind of the drug because the only newer drug is coming from some pharmaceutical company. So Japanese doctors' trial have already finished the accrual of the patient. If we see the KRAS G12C positive patient in first line setting, we give the sotorasib plus carboplatin plus pemetrexed. Now the result is following, not that yet, but maybe the response rate, the primary endpoint was overall response rate. We assume that response rate may be higher than sotorasib itself. So the important thing is how long the response to be durable. Maybe you don't have the sotorasib or adagrasib so far. So, but one good information, if you see the KRAS G12C patient, positive patient, the immune checkpoint inhibitor, including pembrolizumab, may be effective for the patient with KRAS mutation. This was very unique findings. This trial was done by the pembrolizumab company, the Merck, comparing the called Keynote 042, and their sub-analysis. If the patient have a KRAS mutation positive, the efficacy of the pembrolizumab is better than chemo, and especially with the KRAS G12C. This was subgroup analysis, and then FDA have already done the real-world data analysis, and they also say that if the patient have a KRAS mutation positive, still ICI is effective. But we think that EGFR ALK, they're not, the patient with this kind of the EGFR ALK, it is not suitable for the ICI so far, our design, but the KRAS is different. And this is the summary of the KRAS. KRAS G12C inhibitors are active. The activity of the KRAS G12C inhibitor monotherapy is not so strong enough for the first line treatment for the patient with the mutation. And chemo and ICI should be given earlier so far. At least I should be given in my mind. This is final slide, conclusion message. KRAS have long history as oncogene and also brand new aspect as target of the newly developed agents. Progress of the clinical and translational research on lung cancer have been changing the practice of the testing and treatment over decades in your country also. Both clinical research, translational research, and real-world evidence and experience of your patients and our patients are essential for the future progress of the patient with lung cancer. So please continue to connect and changing the information of your and our experience. Finally, I will try to say, Kam un tat ka moi goi. Thank you very much.
Thank you very much. So now I'd like to move to the discussion part. So please remain on the stage. So we'd like to accept questions from the audience. Oh, so there are several. So the first question is, what are the requirements for the blood sample to test liquid biopsy? How long should the blood sample be collected after the first administration and during treatments? So this question may go to Dr. Lee. Dr. Lee, can you answer this question?
Yes, I'm here. The question is about the requirement for blood samples to test liquid biopsy, and how long should a blood sample be collected after the first administration and during treatment. It's a really very complex. It's not easy. So based on my limited experience in liquid biopsy, I did see some, should I say, it's a negative liquid biopsy result. And after that, I learned some issues. First, sometimes the liquid biopsy might be limited by a relatively low tumor fraction. For example, we have there is a recent study published by Foundation Medicine in 2022 this year, and in that we learned for non-small cell lung cancer, around 30% cases might have a tumor ctDNA fraction lower than 1%. It's a quite a ratio of patients might have low tumor fraction. So, and second, some patients might receive blood transfusion, especially plasma transfusion, that will lead to a higher ratio of contamination of other DNA, the ctDNA from other people. And treatment will also lead to a low tumor fraction. That is, we usually consider if a patient receives chemotherapy, we should avoid perform liquid biopsy within 2 weeks of the chemotherapy. But there is no guideline for that. That is only my personal experience. Thank you.
Thank you. So next question is, blood NGS results can be from the other organ, not lung cancer. How can we differentiate the results from lung or other organ? I think it is complicated, and blood NGS results can be wrong sometimes. That cannot be answered by tissue heterogeneity. So it's a bit difficult question. Any volunteer to answer this question?
Yeah, I think I can try to answer some. Is that okay?
Sorry?
Excuse me?
Yeah, please answer. You volunteered.
Yes. Yes, it's true, because when we see a mutation, it's almost not possible to differentiate the origin of the mutation. But now, some biotech companies try to differentiate the organ by using the promoter methylation profile, because the methylation profile from each organ might be different. So incorporate with the methylation profile, it might be possible to learn where the mutation comes from. I think at least some mutation can be judged for its origin.
Yeah, so if you find the EGF mutation from the blood, the likelihood from lung cancer is high,
yes.
right?
Yes, yes.
So those kind of things
Yes.
present, but sometimes it's very difficult to differentiate from what organ this mutation is derived. So the next question is, which regimen should we choose? I'm sorry. Which regimen should we choose if the disease is progress after sotorasib? So Dr. Kato.
Thank you very much. You usually give the chemo and IO before the giving sotorasib. So usually we give docetaxel plus ramucirumab in Japan. But actually, we don't have the appropriate treatment for them. So now we are trying to give docetaxel mainly.
So next one, how different between de novo HER2 mutation versus treatment failure HER2 mutation? So this question will go to Dr. Kim.
Yes, usually de novo HER2 mutation would be the exon 20 insertion mutation with 4 to 12 amino acid. That means when you see other point mutation, you should expect some kind of result from other treatment, especially around the drug binding site. And actually, usual result mechanism from HER2 inhibitor is usually amplification.
Yeah, so it's rare to see the YVMA insertion after the failure of the HLTKI, right? So that's
yes.
what you mean. So okay, thank you. So the next one is how can we in the near future? Do you think ADC combination with IO will play a role instead of chemo IO combo? So this is for Dr. An.
Yes, I think currently the ADC like a TROP2 DXD is combined with pembrolizumab or other immunotherapy is being investigated. So in the near future, the platinum-free regimen might be can replace the platinum-based chemo IO. So I think it will be possible, but we still wait the result. The study is ongoing.
Yeah, okay. I have a related question. So you said that for the ADC for the TROP2 or CEACAM5 are not selected by its expression, but some other are selected by mutation or expression. MET, in the case of the MET, the patients are selected by MET and that affect. So, but if we select a patient but TROP2 was not related to the efficacy, right? CEACAM, how about the CEACAM? So I'm a bit confused. Some are selection, some are not selected. So do you have any?
Well, still we don't have any enough evidence that the expression of those targets, like the TROP2, CEACAM5, or HER3, is related to the clinical efficacy. So it's a little controversial so far. So I think we need more data. But as far as I'm concerned, the DATO-DXD, the TROP2 expression doesn't seems to be correlated with clinical outcomes. But the clinical trial will provide more evidence.
So one primitive question is the CEACAM5 expression level related to the serum CA level? Do you have any data? Do you know any?
I have no idea, sorry.
Okay. Okay, next question is, how can we approach remaining KRAS mutation other than G12C? Dr. Kato.
How can we? I'm not sure, but KRAS have other mutation other than G12C. Just 1/3 or 1/4 is called G12C. The others are including G12A, G12D, G13C. Anytime we see, oh, patient have a KRAS G12, but unfortunately, not C. The sulfur agent have already tried, and other combination have tried, but so far we didn't have fascinating data. But we need to continue the clinical trials using the other kind of the drugs.
Yeah, that's a very competitive field. So that many drug companies are trying to develop the drug for the KRAS mutations other than G12C. But yeah, we don't have the promising agent yet. At least in vitro, there's some nice data.
You also expect for that in vitro study. Kind of that allosteric effect is very sensitive for the just one change of the amino acid. So G12C is only the gene alteration captured by.
Also, cysteine is one of the two amino acids that can form the covalent bonds with the drug. So that's why sotorasib was initially developed for suppress the KRAS activity. Okay, so I have several questions. So about the gene testing, so that you and Dr. Lee told about the efficacy of the amyloid test, so the multiplex RT-PCR test. But in Japan, also the OncoMind NGS platform is popular. So it is, of course, related to the availability of these tests and also cost reimbursement status. But if those problems are not present, what do you think is the best? What test do you think is the best?
Okay, then I will start. For the Japanese experience, the AMOI91 is very easily because the failure rate is just 1 to 2%, even in an RNA. Comparing the OncoMind, the former, we missed the 30% of the patient's data because the lack of enough nucleic acid. But next week, our team will present the needed amount of the nucleic acid for the amyloid, around 1/10, just 10% to the amyloid. So that will be result in a high rate of the success.
But initially, the OncoMind test in Japan was, the success rate was low, but now it's becoming better. So if we run by time, then the success will be improved.
Yes, the success came from our trial for how much of the specimen we get for the NGS testing at the time of the bronchoscopy. The other one is how to select the patient specimen to submit the OncoMind. So the failure rate getting decreased because both the amount of the specimen getting bigger and then selection getting much smarter.
So I'd like to please
yes,
let me know the Korean status.
Yes, in Korea, we usually use the Illumina platform. So the TrueSight 500, the turnaround time is quite long, as it takes about 6 to 8 weeks. So it's not tolerable for the patient, especially stage 4 disease. So I heard that recently the OncoMind DXD is approved in Korea too, and it will be reimbursed. So compared to the Illumina platform, the OncoMind DXD require only 5 nanogram of the DNA, and the turnaround time is less than 10 days. So I definitely use the OncoMind DXD for the treatment decision. However, because of the small panel, I think to look at the other alterations, I think if the OncoMind DXD was negative, then consider the large panel.
How about the Amoy test? Do you use Amoy test?
We don't use that, actually.
How about Dr. Kim?
Yes, actually in Korea, each hospital has its own lab-based test. So we are using PCR and immunohistochemical stain for ARC and NGS. Actually, NGS is our lab-based test. Our hospital's turnaround time is about 2 to 3 weeks.
Thank you. So the next question from the audience is, what is your real-world experience of capmatinib? What about drug-related adverse events? So, Dr. Kato.
Yep. As I told you, capmatinib, tepotinib is same class, and then efficacy and toxicity is very similar. So there's no difference. So the main adverse events, chemistry change, like the elevation of creatinine, of elevation of some hepatic enzymes. So
do you know the mechanism of the pleural edema?
Actually, so far, nobody in the world knows.
Any additional comments from Dr. Kim or Dr. Ahn? No?
No, actually, capmatinib is a quite good drug for patients, except MET-associated side effects such as peripheral edema.
Okay, thank you. How do you handle patients with concurrent KRAS and EGFR mutations? This is difficult.
I've never seen this kind of the mutations with EGFR and KRAS, but we see the KRAS mutation positive EGFR amplified patient. At the time, we give the KRAS drug like sotorasib, but actually I don't know, but usually some mutation or findings of amplification, the response rate and duration response tend to shorter and smaller. So at the time of the giving the drug, we have to notice that what kind of the mutation exists for the patient.
Yes, so in general, it's very rare to see to have the both KRAS and the EGFR at the same time. Actually,
yes, two mutations are mutually exclusive, but you know, KRAS mutation is one of release mechanisms of EGFR TKI. So sometimes you can see KRAS mutation after EGFR TKI progression, but in that case we don't know. Currently we are just treating patients with chemotherapy, but we may need more treatment options.
How about the combination of the sotorasib with osimertinib?
Maybe, but we have no experience.
Okay. So maybe the final question is, dear professors, if the patient non-small cell lung gets a PD-L1 49% and KRAS HER2 plus its expression, can treat within targeted therapy or combining with IO. So the PD-L1 is positive but not very high, and KRAS HER2 plus maybe in the expression or mutation, I don't know, but how do you treat?
Maybe that this question is regarding to the KRAS positive or HER2 positive. Those two drugs is now the post second line setting. So in practically based on evidence, we give the chemo plus something. But in Japanese experience, we give chemo plus IO as a first line setting combination after.
Maybe KRAS and the HER2 will be different, right? KRAS immunotherapy may work better than HER2, right?
KRAS, we have a data of the only KRAS, and I'm not sure the HER2 data.
Yeah, but my guess. How do you think, Dr. Kim? I mean, the patient with HER2 mutation, how do you think about the efficacy of the IO drug?
Yes, there is no prospective trial, but there are some retrospective reports that the IO for HER2 mutated lung cancer is a little bit limited. So we need some data. Okay. In this case, I guess
we should focus on KRAS mutation itself.
Okay, so the final question. Is there a difference of melanoma's pseudo-progression versus lung cancer with IO treatment? So that the difference between melanomas and non-small cell lung cancer in terms of the pseudo-progression? Anyone can answer?
Definition, yes, definition of pseudo-progression is quite variable among the studies, but definitely the incidence of pseudo-progression is very high in malignant melanoma, it's around 13%, but actually in lung cancer, the incidence is quite low, around 3 to 5%. So usually we do not see the pseudo-progression in lung cancer. The most of the patient who progress as a real progression. So I think the incidence is quite low, but actually the definition of pseudo-progression is different among the studies, and so that's why the instance is variable.
Okay, thank you very much. So we have only 14 seconds left, so I'd like to close, and I'd like to thank all the speakers for the very nice talk and also the Q&A session. Thank you very much.
Thank you.
Thank you.
Thank you.
Great, thank you so much, everybody. Can I just invite these speakers here in Hanoi on stage for a group photo? And to all our delegates, thank you so much for staying with us all the way. We wish you a... Oh, sorry, Professor Mitsushima, go ahead for the closing remarks.
Thank you very much for staying until the very last moment of the... So by comparing to the morning, the number of the participants will be less now. So you may have exhausted with enormous amount of the knowledge presented today, but I hope and thanks to the Boehringer Ingelheim and other sponsors for this meeting happen. And I'd like to briefly wrap up. You may have exhausted it, but please remember. So in the discussion one, I reviewed the relevant discoveries presented this year. So, and Dr. Coy shared the strategy to address the lung cancer treatment during the COVID-19 early stage. Dr. Khan sequencing, especially afatinib for the biosimilar strategy. Dr. Mauk, third generation combination and other inhibitors for EGFR mutation non-small cell lung cancer. And Dr. Taiwan guided participants on the real world evidence in EGFR mutation non-small cell lung cancer. And discussion 3, we discussed the immunotherapy, and Dr. Chua discussed the biomarkers of the immunotherapy. Dr. Yang presented the first-line treatment of the IO. Dr. Ahn provided a resistance mechanism of the IO therapy. And finally, Dr. Wu presented the perioperative therapy of the Dr. Lee, and Dr. Ahn talked about ADCs. And Dr. Kim talked about the HER2 exon 20 mutations. And finally, Dr. Kato discussed the MET14 skipping, MET amplification mutated, G12C mutated lung cancer. So that's what we learned today. So thank you very much for your active participation. You were so active in questioning or participating in the discussion. And we look forward to seeing you soon somewhere. Maybe some of you may attend the ESMO Asia next week. Feedback from before you leave. And thank you very much for all your help.